Is This Normal, Doc? A podcast sponsored by Tanner Clinic.
Welcome back to another episode of Is This Normal, Doc? The podcast where we talk about what's normal and what's not with the expertise of our Tanner Clinic providers. I'm Hope and I'm your host, and today joining me as my co-host is Victoria. Victoria, do you want to introduce our guest today?
Of course. Today we have Dr. Thurston. He is a family and sports medicine provider at Tanner Clinic, and we want to give him the opportunity to introduce himself.
Yeah, thanks, Hope. Thanks, Victoria, for having me on this podcast. I'm really excited. Like you said, I'm Dr. Mac Thurston, and I'm from the area, hometown boy from Morgan, Utah, not too far away from Davis County. I've been at Tanner Clinic for about 9 years now. Some of my background as far as my education and training goes, I've really been all over the country. So when I married my wife, she played volleyball at Northwestern State, which is a small school in Louisiana. So I did undergrad with a major in biology there and went on to do medical school in Puerto Rico. And then I was fortunate to get accepted to residency at Mayo Clinic in Minnesota and did my family medicine, my primary care residency there, and then did my fellowship in sports medicine, non-operative sports medicine or primary care sports medicine at Mayo Clinic in Jacksonville, Florida. And then I came straight to Tanner Clinic.
Puerto Rico's cool, and Mayo Clinic's got a great reputation, so.
Yeah, no, I really felt fortunate. Puerto Rico was awesome.
Not that med school is like the funnest thing that you've ever done, but that's a cool place to do it.
Yeah, there's some things that you like about med school, but a lot of the time was spent in the library. My wife was enjoying the beach with our kids.
That's where I would be, too.
Yeah, so she was kind of jealous though because I got air conditioning in the library while she was out in the heat. But no, I would have much rather been on the beach than in the library in med school. But enjoyed my time there, made a lot of really good friends, and then like you said, like #1 hospital in the country, Mayo Clinic. Like I felt super fortunate to train with some of the best. And it was a really, really fun experience. A lot of work, obviously, a lot of time, but I really loved both of those experiences.
It's not the easiest thing to take a busy doctor out of his schedule and come on to do a podcast, but we appreciate you.
Yeah,
and I'm sure these guys will appreciate you once we've talked about what we're here to talk about today. But first, we're going to do our new favorite segment that we like to call, Is This Doc Normal?
So what I like the most about this segment is that we get to find out if the doc is normal or not. So who is your favorite fictional doctor?
Well, first, I don't think I'm normal, but
we get to be the decider of that. Thank you.
I can tell you that right now. I know that's a tough one. I'm gonna go with three different doctors here. I'm gonna go old school Hawkeye Pierce from MASH.
MASH.
Okay.
I love
you guys
MASH.
Probably too young, but
no, I watched it with my mom.
No
my
way.
mom knows every episode of that show.
BJ Honeycutt, Hawkeye Pierce, like those are pretty cool guys. My wife roped me into watching Grey's Anatomy, so Derek Shepherd, Mr. McDreamy, and I can't, House is that doctor that, I think a lot of us wish we could say those things sometimes, but never do, because it's probably not appropriate. But I like.
I'm surprised he didn't get sued more. Let's be real, in the show, but
no bedside manner. No.
Yeah, so I don't know. I couldn't necessarily pick one. I picked one maybe from each era there.
Well, it's kind of cheating, but we'll take it. But I love those answers, too. We just threw this question in here because we've heard some things, but what's your nickname at work?
Well, I do. There is a patient that she got my last name and my first name mixed up, and so my first name is McKinnon. My last name's Thurston, obviously, and but she just, I think McKinnon and McDreamy came to her mind. And so she called me McDreamy, and then that kind of got spread amongst my colleagues and those that work at the office. So not my favorite nickname or what I picked, but yes, I did get labeled with that a little bit. But yeah, my nickname is Mac. That's what most people call me.
We're like, we have to add that in there.
Sorry
People
to put you
know.
on the spot.
Not that you picked that for yourself, but
I didn't know that you guys knew about that.
Oh,
so.
yeah.
It has spread. Don't you worry about it.
Okay, what about if you had any other career? What would you do?
I would probably mow lawns.
Okay, I love
really?
that.
Yeah.
Are you one of those guys that really likes a nicely mowed lawn?
Mm-hmm.
I love watching those videos of the guy. He's like, there's a rock in my yard, and I can tell because this patch of grass is dying. And then he digs out the rock. And
Yeah, there's like some sort of satisfaction just mowing a lawn and having it clean and straight lines that I really enjoy.
Is yours the yard that everyone is jealous of in your neighborhood?
I need to spend more time on it, but
Yeah.
if I had a little bit more time and money didn't matter and I could do that full time, I would really enjoy that.
That's like the ultimate dad job then. You'd be out there with like your white shoes, your New Balance shoes, mowing the
your shirt a
lawn.
little?
Your
New
shirt would be
Balance,
tucked
like
in.
the Velcro ones.
Yeah,
I'm not like that old.
Okay, this last question I have to read because it's so detailed, but it's our would you rather question. It's, would you rather have to fight one crab with a knife once a year or be chased by a slow-moving but unkillable turtle forever?
Does the crab have the knife or does
The crab has the knife.
Okay.
And I don't have any weapons.
It doesn't specify, so I think you can leave that one up to interpretation.
I mean, I am a super impatient person, so like being chased indefinitely by a turtle sounds awful. I'd rather have a quick death myself, or
Do you think
like
you would die if you were
take the
fighting a crab
out.
with a knife?
I mean, and I think I could take the crab.
Yeah.
Yeah.
I was gonna say,
I mean,
He's small.
You just step on it.
Yeah, I mean, how big could his knife be?
What if it's
Who
a king
knows?
crab? They're pretty big.
I mean, they're pretty big.
Yeah, it depends on the crab for me, I think. And the turtle, they didn't. Here's the thing: it didn't specify if the turtle was trying to kill you.
That's true.
It
He's
said the
chasing.
turtle was unkillable,
Yeah,
but I'm assuming it's trying to kill you.
yeah.
But even so, turtles are slow, so you could just like go and move to a different country. And then
You guys have not owned a turtle. I have a tortoise. They're not that slow.
I've watched your tortoise,
She
A
whips
real
around.
tortoise?
Yeah, I have a tortoise.
but like compared to a
That's
car,
cool.
she's slow.
I mean, yeah, but like I've literally put her in the living room, turned my back for like 1 minute, and she's gone. I don't know where she is. I would rather take the crab too.
You agree?
Mm-hmm.
Yeah, yeah,
I agree, but I also am confused about the turtle one.
yeah. I mean, it's a
So-
pretty cool turtle if it's unkillable and it can go forever.
Yeah. So we're going to get started into today's topic, and you are a sports medicine provider and you offer some services that are not surgical. So I wanted to talk about, first off, why sometimes surgery isn't always the best option.
Well, I think even my surgical colleagues would agree that 80% plus of orthopedic injuries are just non-surgical. I mean, you think about the simple things, obviously a sprained ankle, a lot of times tennis elbow, even an acute shoulder injury, most of the time is not necessarily a surgical injury. So I think that's where the services that I provide can come into play, is to help diagnose patients with the correct and accurate diagnosis, and then help them with whatever that treatment plan might be.
Yeah.
Obviously, I would never hold a patient back from surgery if they need it, right? So I think there are some injuries where surgery is pretty obvious as far as the answer. An acute ACL tear in the knee, right? That is something that in majority of cases needs surgery. So I think in those cases, I certainly am not going to hold a patient back from seeing a surgeon, but there are a lot of issues, orthopedic issues, that we can help resolve with physical therapy or some of the treatments that we offer in our clinic.
Speaking of that, what are some things that people might think that they're needing a surgery for, but in reality, it's probably better to see a sports medicine provider first? Like if I dislocate my shoulder, that doesn't necessarily mean I need surgery right away.
Yeah, I think that's a really good example, an acute shoulder dislocation. Now, statistically, we know that the younger the athlete is when they have a shoulder dislocation, the more propensity they have for recurrent or repeated shoulder dislocations in the future. So if it's a younger athlete, I actually might be more inclined to send that patient to a surgeon to at least have a conversation. But let's take a 30-year-old patient, for example, that dislocates their shoulder for the first time. I don't think it's unreasonable for that individual to pursue a non-surgical treatment plan. A lot of times that includes, like I said earlier, physical therapy with a lot of strengthening to try to stabilize and keep that shoulder from getting injured again.
Yeah. And just to clarify, you don't have to, dislocate it in a sports related thing to see a sports medicine provider. Like you could dislocate your shoulder sprain your ankle doing things that aren't necessarily like a sport?
Yeah, I get that question actually all the time, or sometimes jokingly patients will say to me, well, I'm not an athlete, so I'm not really sure why I'm seeing a sports medicine doctor. But the reality is that we treat all orthopedic injuries, and you do not have to be an athlete to come see us in our office. In fact, I would say the majority of the patients that we see are not necessarily professional or even amateur athletes. You know, they trip going down the stairs and they fall and hit their shoulder or hurt their knee or whatever it might be. And we're happy to see that patient and try to help them come up with a treatment plan.
I feel like people might get like embarrassed about that kind of stuff, but I'm like the most clumsy person I've ever met. So I think just knowing that like a lot of the patients you see aren't sports related might help people feel a little bit better, especially me. Like if I fall down the stairs, I can still come in.
Yeah, definitely.
No, it's not a sports injury. I might lie about it. Just kidding.
I might be like, yeah, so actually I was...
Yeah, you need to come up with a story, a good story.
Competition volleyball beach tournament. When in reality, I just like fell getting out of my shower or something.
Seriously. Are there any risks that you found where people want to jump into the surgery first thing? Are there any risks associated with getting like surgery too early?
Well, I think there are inherent risks to surgery that are always going to be there, right? So, you know, a surgeon has to consent a patient to those risks, and they are real. Now, it doesn't mean that they happen often, but any surgery brings with it risk of bleeding, risk of infection, and so, yes, there are inherent risks to surgery. So I think that, you know, sometimes if a patient rushes into that and they have a complication, obviously there's regret. You know, well, should I have done this surgery? Now I have, you know, another thing to deal with instead of just the initial thing I went in for. So I think that if we can, again, come up with a really good treatment plan for the patient and surgery is not an option at that time, by all means, I think we should pursue that. And I think most patients would agree.
I don't know of anyone who's signing up for major surgeries. And
I mean, there's probably
I guess if you were in
a
enough pain, though, you might just be like, hey, let's just do a surgery and get it over with. So I can see that, too.
Yeah, I think that sometimes patients do get to a point where they may be desperate, you know, dealing with chronic pain all the time, and the impact that might have on a patient's day-to-day life is exhausting and overwhelming, and sometimes they're just looking for a fix. But the fix isn't always surgery.
I get married in a couple months, so I'm not doing a surgery before my wedding. Like, I'm just not doing that.
Yeah.
I don't want to be in a sling on the dance floor.
Yeah, I think that's like, you know, patients just really kind of knowing what they're getting into. And if you haven't had a surgery before, you don't know. But yeah, if you have a shoulder surgery, in a lot of cases, you're going to be in a sling, immobilized for 6 weeks. And then you've got physical therapy. And so a lot of times
I was like, well, what if, you know, I get an infection post-surgery and then, or it didn't, you know, I re-snapped something. Well, then I'd have to go back again. And I was like, I'll just wait.
Yeah, I think it's, you know, it's smart. And your particular injury, you know, if there's a labrum or a piece of cartilage that's injured in the shoulder, you have time.
Yeah, I mean, it's been torn for like 12 years, apparently. I heard it when I was a kid, and then the initial MRI told me that I had maybe a slight tear, but obviously as I've gotten older, it's gotten worse. I've had redislocations. Like, this probably happened when I was 13 years old, so it's like just chronically getting worse. And the other day, Hope literally saw me reach for a soda can and going, ah. Like,
she literally made like the worst sound. She goes, oh, don't mind me. I was like, she's literally just trying to grab soda. I was like, oh,
yeah.
Great.
Well, I think
but I can deal with it.
Yeah.
I don't even take ibuprofen. Like, I just grit through it. And that's probably not healthy either. But like,
what else are you going to do?
What else am I going to do?
You're getting married. But I would like to point out that there are some injuries that, you know, shouldn't be ignored and shouldn't be left too long. So, you know, we could take the shoulder for another example. We talked about a labrum injury, but versus a rotator cuff injury, for example. So if you completely tear a rotator cuff tendon, there can be retraction of that tendon, and it makes surgery a lot more difficult the longer that you wait. So
I see.
I do think that certain injuries, you know, it's important to be evaluated early on so that you know how aggressive you need to be with the workup and with the with the treatment.
So even if you're unsure, you should probably just go check it out.
Yeah.
In case that there's anything you need to do.
Yeah.
So it doesn't get worse.
Yeah.
So I want to get into more of the specifics of some non-surgical things that I know that you do. One of the procedures that you do is the 10X procedure. So can you explain what that is and what it treats?
Yeah, for sure. I love the 10X procedure. I'm going to use some medical jargon, but I'll try to explain it in layman's terms too. The actual medical procedure is percutaneous tenotomy, and percutaneous just means through the skin. Tenotomy just means open the tendon. So we're able to do this with a very small incision, a 4 millimeter incision. The whole time we're using ultrasound imaging. We're looking at the tendon through an ultrasound image, and that's why we can make the incision so small. Through the incision, a needle is placed, and the needle is connected to a machine, and it's the 10X machine. And what the 10X machine does is it moves the edge of that needle back and forth at ultrasonic speed. What we know in these chronic tendon injuries is that there's a lot of scar tissue that starts to form, and it inhibits the actual healing of the tendon. Yeah. And patients can end up having symptoms for months and sometimes even years. And so the purpose of the procedure is to remove that scar tissue. The movement of the needle back and forth at ultrasonic speed breaks up the scar tissue. And then there's 2 tubes that are connected to the needle. One of the tubes has saline that pushes into the area and mobilizes the scar tissue. And then the other tube is a suction tube and suctions the scar tissue out, and it collects it in a bag on the side of the machine. So it's very minimally invasive. There is a tiny scar. We don't even use sutures or stitches to close up the wound. Well, we just use some steri strips. We cover it with a piece of gauze, apply a little bit of compression to the area after the procedure. Depending on the body part, we may put the patient in a boot or a sling for a few days. But other than that, they're really moving around within days of the procedure. Now, I tell patients, as opposed to surgery, like we're not going in and sewing things back together. So what we're doing is we're removing that scar tissue that's inhibiting the healing, and then the body is stimulated to then go ahead and heal the tendon. And that process takes time. So it's not a healing overnight, but rather 2 or 3 months down the road, that tendon will be fully healed. It's pretty impressive how a lot of my patients seem to feel pain relief within the first few weeks, and then they start to develop more strength as the tendon heals, and we expect full recovery around 3 months.
Just to give them more of an idea of like what to expect if they do get this procedure, is this something that they're put out for, or are they staying awake for it? Is there any like pain associated with the procedure? Yeah,
that's a really good question too. So nearly all of the patients that we've treated with 10X do not go under general anesthesia. Okay. It's a local anesthetic in that area. We do make sure we numb it up really well. The patient's awake, so they're able to communicate with us if they don't feel like they're numb, which we check before we get started, then we'll numb some more. In a few cases where the procedure might be a little bit longer, or I feel like there's a little bit more of a bone spur or calcium that's built up that might be a little more painful, then that patient we might put under a light sedation for the procedure.
And do you do that in office, even if it's a light sedation?
No. So if it's a light sedation, we'll definitely be at the surgical center. And unfortunately, with how insurances view this procedure, we actually need to do it at the surgical center.
Okay.
And that's more, again, of an insurance thing. I have done it in the office if the patient is paying cash for the procedure. Maybe they have a high deductible, maybe they don't have insurance. And so we'll just go ahead and do it in the office because it is very simple. It is a local anesthetic in the majority of cases.
Who are like the candidates for this type of procedure?
Any patient that has had a chronic tendon injury, and I would say that's gone on at least 3 to 6 months without healing. I strongly encourage patients to pursue physical therapy first, and there are some different treatment modalities that they use in physical therapy that are helpful for these chronic tendon injuries. I'll name just maybe a few, but they'll do what's called tendon scraping. It feels about like it sounds. The physical therapist will use some special tools that will, from the outside on the skin, try to break up scar tissue. So it has a similar philosophy of what we're doing, but we're going inside the tendon. They also will sometimes use what's called extracorporeal shockwave therapy. So they also will use ultrasonic shock waves to try to break up that scar tissue from the outside. So if a patient has really tried to modify their activities, maybe they've rested for a while, they've tried physical therapy with these different modalities, and they're just not getting a response, then that's the appropriate patient to refer to my office and to consider the procedure.
Are you able to see the scar tissue on the ultrasound before you do this procedure? Like, how do you know that there's scar tissue there?
A lot of times these patients will come in with an MRI being done, which is a really great imaging tool to see details, to rule out any major tears that might need more of a procedure than what we can offer. But a lot of times if they don't have an MRI, yes, we will ultrasound the patient in the office. And under ultrasound, the scar tissue actually has kind of a dark appearance. And we look for those areas. And sometimes patients will have partial tears in the tendon as well, but those partial tears actually respond really well to the treatment.
What can someone expect after this procedure as far as like healing goes?
Immediately after the procedure, depending on, patient preference, but a lot of times we will provide them with a pain medication for the first couple of days. Like we talked about earlier, they will probably be immobilized again just for a couple of days. We actually encourage early mobilization, so early movement of the joint or the tendon, just to try to make sure that we can regain range of motion as quickly as possible. We're really going to limit the amount that the patient lifts in terms of weight for those first couple of weeks. After those first couple of weeks, though, we're going to gradually load the tendon. And what I mean by that is that a lot of times in these chronic tendon injuries, there wasn't a specific moment when they got injured. It was gradual in onset, and the tendon got overloaded. Yeah. And so what we want to do is try to get that tendon used to a certain load or weight, but do it in a gradual fashion to build up that what we call tensile strength. I wanted to talk more about which areas of the body can be treated with 10X. Initially, 10X was developed at my alma mater, Mayo Clinic, roughly 15 years ago, and it was introduced by a non-operative sports medicine orthopedic specialist who borrowed the technology from cataract surgery. I know that sounds weird and maybe a little odd, but in cataract surgery, they use what's called phacoemulsification. That's a really Latin and medical word, but basically it means to break up unhealthy parts of the lens, the cataract part. And so they use this ultrasonic energy to break that up and suction it out in a safe way. This doctor in Minnesota somehow thought that maybe we could use that on tendons. And so that's what he started doing. And he approached an orthopedic surgeon specialist in elbow surgery, and they used it first on tennis elbow. They identified those areas of scar tissue and were able to remove it, and these patients did really well. In fact, sometimes they do better than even the open procedure that sometimes surgeons would do. So from there, they were able to say, well, if it works in tennis elbow for chronic tendon injury or chronic tendinopathy, why wouldn't it work in other areas of the body that also have a lot of scar tissue buildup from chronic tendon issues? And so we really can treat most tendons of the body: rotator cuff, the side of the hip, the gluteal tendons, patellar tendons in the knee, Achilles tendon, plantar fascia. It's really been a helpful tool in helping patients to recover from these injuries. Patients will have bone spurs that will build up in these areas and can kind of predispose them to some plantar fascia issues or even some Achilles tendon issues. And so the technology of 10X has evolved to really be able to treat even the bone spurs too.
Well, next we wanted to ask you about PRP, which is platelet-rich plasma.
Yeah, so I think that PRP has a role as well in chronic injuries, maybe a role even in acute injuries. There's still some studies about acute injuries, but those chronic injuries, definitely I think PRP has a place. Again, I want to emphasize that, we don't start out with PRP or some of these interventions. I think that having patients do different treatments with physical therapy is a really good place to start. But if they're not responding to those treatments, PRP, like you mentioned, is platelet-rich plasma. So
is that from your own plasma?
Yeah. So it's very safe because we're just taking your body's own platelets and we are concentrating them in a centrifuge. And we concentrate those platelets 10 to 12 times the normal concentration. We know that platelets are full of different growth factors and different growth hormones, cytokines or proteins that are really helpful in the healing process. Let's take tennis elbow again for an example. A patient's been dealing with this chronic pain. They've tried different treatments, not responding. And what PRP does is we use the ultrasound image to identify those areas of scar tissue and areas of partial tendon tearing, and we insert the needle directly into the tendon with the PRP. The intent of PRP somewhat is to restart the inflammatory process. So we want inflammation to be there to try to help with the healing. And obviously the PRP is packed full of all these good proteins as well and hormones that will help to stimulate the healing of the tendon.
That's super interesting because I always feel like when you have an injury, they say, oh, take anti-inflammatory medication. But how does making it inflammatory help with the healing process? Is it because of those hormones in the platelets and in the plasma? I
really think that philosophically we may be changing a little bit of our approach, even myself, in what we used to do. You know, we used to encourage ibuprofen or anti-inflammatories early on in injuries, but that might not be the best idea. We know that inflammation is actually probably bringing...
it's part of the healing process, right?
Right. It is part of the healing process. So it's bringing those healthy hormones and proteins to the area. So PRP works in two ways. One, it directly inserts those things into the area of injury, but it also initiates or ignites an inflammatory process in the body. And we don't want to diminish that with ibuprofen. So ibuprofen or anti-inflammatories actually, they're counterproductive to PRP.
And so what are the most common injuries you would see that you treat with PRP? You said chronic, but is there certain parts of the body, or are there certain tendons or certain areas that work better with it?
Studies have shown that there are certain other areas of the body that seem to have more positive outcomes with PRP. And I don't know if I necessarily have the answer to that, because you would say, well, isn't a tendon problem in the elbow similar to a tendon problem in the knee or the ankle? But the studies on PRP do show that the outcomes are most positive in tennis elbow and actually for mild to moderate knee arthritis. Those are the two areas that have really, really positive outcomes. When a patient has been suffering with a tendon injury for a long time, we really will try PRP anywhere. We will inject it into the shoulder, we can do it into the rotator cuff, we can do it into these other tendons of the body with the hopes that it will have that same response. Yeah. But in terms of statistics, the elbow and the knee are probably the most positive.
I just had one other question about that. You're taking your own blood. Is that a long blood draw? Like when you're giving blood, they take a whole pint?
Yeah, so it's definitely going to be a larger amount than a simple blood draw to do labs, but it's not going to be as much as what you would donate if you went to donate blood at a blood bank, for example. We usually draw 90 to 120 cc's. It is more than a blood draw.
Okay. Just curious, because I know some people are a little afraid of needles and that sort of thing, but the benefits probably outweigh the fear of a blood draw.
Yeah, and I wouldn't say that the blood draw to get the PRP, it's not one of those you got to come and sit down for 30 minutes to get all that blood. It really only takes 4 or 5 minutes.
Okay, that's good to know.
I think maybe another important part of PRP that I try to tell patients is that I'm sometimes cautious about this, but I want to be honest with patients. PRP hurts. So because we are concentrating platelets and putting that into an area that's injured.
Pushing all that fluid right into one spot. Yeah. It's probably a little uncomfortable.
Yeah, I would say that it varies because pain scales in patients vary, but we numb the area, but still the PRP seems to overpower some of the numbing. So I give patients a heads up that Tylenol is probably your best friend. We can't use anti-inflammatories because that kind of ruins the purpose of the PRP. And I think if they have a high expectation that, hey, this is going to hurt, and they know that, they come in and they usually handle the procedure just fine.
Appreciate the honesty,
we don't want to
know what to expect when you go in there.
We don't
it doesn't hurt at all.
Yeah, it's just a little pinch.
It's just a little pinch.
Yeah.
It's always good to hear from a doctor, though, that they will admit that it hurts.
I'm not going to sugarcoat this one. It is uncomfortable. It's usually those first few minutes during the procedure and right after that it's most painful. And then it calms down, and then it's sore. It's going to be sore for a week or two.
I was going to say, how long does it usually take for the inflammation of the PRP to go down?
Yeah.
Or like when can you start taking like other over-the-counter pain relief? You said Tylenol's fine, but like no other anti-inflammatories for about how long?
I try to encourage patients to really avoid them as long as they can, but I think at least 3 weeks is a good amount of time to try to avoid those anti-inflammatories. But really, similar to other tendon procedures, it takes about 3 months for that tendon to remodel and repair and to heal. And so if we can, we'll try to avoid those anti-inflammatories that whole time so that we have the best opportunity to allow the tendon to heal.
So, last one we wanted to talk about was stem cell therapy, something that I think is really interesting, but something I know nothing about. So, and I'm assuming probably most of the people listening and watching know nothing about it either. So, what are stem cells and how do you get them?
There are different types of stem cells, but the stem cells specifically that we use in orthopedics and in sports medicine are called mesenchymal stem cells. And so we harvest the stem cells from the patient themselves. I think that that's the safest way and the most effective way to get stem cells. So we go in through the pelvis and we do a bone marrow biopsy. And we take those stem cells, that bone marrow, and we spin it down in the machine on the same visit. And then we inject it into the area of the body that is injured.
So how does that compare to something like PRP? Is that something that you're doing about the same, or?
I mean, honestly, I would say that a lot of times I convince patients to go with PRP first because PRP is easier. It's just simple blood draw.
Yeah.
And PRP is a lot more cost effective. The process of getting stem cells and doing those injections is more expensive. It's more expensive for us and it's more expensive for the patient, more time consuming. And so there's a cost difference there. And not that everything comes down to cost, but I think that the studies have shown that PRP is really effective in a lot of cases. And so I think it's a really good place to start. In those patients, though, that are excited about trying stem cell, or they maybe have tried PRP and had some benefit but would like to try something a little different that might have a little bit different outcome, then that's the patient that we will go ahead and do stem cell for.
I think another thing that maybe people are wondering, and I don't know, but are these like safe procedures? Like, is there any risks with doing anything like this?
Yeah, I'm glad you asked that question because I think initially when stem cell therapy kind of came out, it was like, is this safe?
Yeah.
Like we didn't even really know. And I think one of the first studies to come out was when I was in sports medicine fellowship in 2015. And that article showed safety. So we do know that stem cell therapy is safe. We can say also from studies about stem cell therapy that it reduces pain and it improves function. I think that we were hopeful, and we still are hopeful, that stem cells might be able to have some regeneration of tissue or growth of tissue. But to this point, I don't think that we can say that statistically it regrows cartilage. But there may come a time when we are able to understand stem cells better, and hopefully we're able to help those stem cells to regrow cartilage and help to repair tissue more effectively.
What are some things that patients might want to ask their doctor, like you, before choosing either the PRP, the stem cell, or the 10X procedure?
They should inform their doctor, how long it's been going on, what treatments they have tried and failed. And really, I think that in terms of outcomes, these treatments are very similar. Like any procedure, none of these is 100%. Roughly, these procedures are about 80 to 90% effective in most areas of the body and for most patients. Again, not everything should come down to money, but the 10X or the percutaneous tenotomy procedure is generally covered by insurance. So if cost is an issue for patients and they have an insurance that will cover the procedure, or maybe they've met their deductible for the year, I think that 10X would be a really good option for them where they wouldn't need to pay for it. PRP Again, I think patients need to know that that one's uncomfortable, but it is something that we can usually schedule and set up rather quickly. So if they're wanting to get a treatment soon, within a week or so, we really can help set that up. We don't have to wait to schedule at the surgical center or wait for a date to open up to do that. We can do it in the office and get it done quickly. PRP does have a cost to it out of pocket. There aren't any insurances to date that will cover this procedure. At our clinic, PRP costs $500 for the first site. Let's say a patient comes in and they want to do both of their knees. We will discount the second knee because we get to use some of the same equipment. So we feel like we can, give that discount to the patient and not charge them, $500 each. So it would be $500 for one joint and $200 for each additional joint beyond that one. Now, if a patient comes in and they want to have 10 spots treated,
you might not be able to do that all in one appointment.
Yeah, they might not want to be walking out of the clinic because that's a lot of...
You're like, maybe let's space this out.
Those are a lot of
inflammation everywhere.
Well, yeah, there's a lot of inflammation going on, a lot of pain with that. But also we don't get enough PRP in one sitting to do that many spots. But, a lot of times we can do multiple spots in one sitting and help the patient to save a little bit of money. And in terms of the stem cell therapy, like we talked about, it takes a little bit longer. It takes a little bit different equipment that comes at a cost. And so the cost for stem cell therapy is $3,000.
And that's also not covered by insurance, right?
Yeah, unfortunately, it's not covered by insurance either. Again, I think that there may come a time when it is. It's been proven safe and it's been proven effective.
Are these procedures something that a lot of sports medicine providers are doing, or is this something that's more unique to you?
There are sports medicine doctors that are doing these procedures in this area, but not very many. If you're looking for a provider to do these procedures, you want to find a provider that has training in ultrasound. Really, that's one of the most important skills with any of these procedures. You need to be able to see the area that's been injured. You need to be able to guide the needle into the area that needs to be treated. I wouldn't go to a clinic or a provider that doesn't use ultrasound. I just think if you're going to pay for some of these procedures out of pocket, you need to make sure that you're getting the treatment to the area that it needs to be. If you're not, then potentially you're just kind of throwing money away. Secondly, I think that if you can find a provider that has done a lot of these procedures, obviously they're going to be more proficient at doing them. In our office, we do these procedures weekly, so we do have a lot of experience. And really we would be happy to sit down and have a conversation with patients about, what is most appropriate for them, what treatment they're looking for, and just how we can come up with a good plan. And it may or may not include these procedures, but a lot of times we are getting referrals from people that they've tried a lot of things. They're athletes, they're weekend warriors, they are people that are really trying to stay healthy and stay in the game. And we want to help them do that any way that we can.
Well, I think we are ready to wrap up, but I just want to thank you again for coming on here, spreading your knowledge.
Thanks for having me on.
It's my free doctor's appointment for the day.
Mine too.
You guys have been great.
I learned a lot. And I just want to encourage anyone to make an appointment with Dr. Thurston if you are struggling with any chronic tendon or joint issues. He can definitely help you out. As you could tell from this podcast, he's done a lot of these procedures and he's very competent at what he does, so we highly recommend him. So give our appointment line a call and you can make an appointment with him. I also want to encourage you to follow along with our Is This Normal Doc journey, to subscribe to our YouTube channel, to like and follow us on our various platforms, and follow us on our Instagram at Tanner Clinic. And you can see all of our updates for future episodes. Thanks for listening and watching.
Disclaimer: the information shared in this podcast is for general informational purposes only and should not be considered medical advice. While our podcast will provide helpful suggestions and insights, every individual's health situation is unique. For specific medical advice, diagnosis, or treatment, please contact your personal health care provider.